All right, well, welcome. Thank you for joining us today. And first, I want to just express my gratitude for you coming out and spending time to watch this lecture and hopefully learn something from it. I am one of the pediatric orthopedic surgeons here at the Andrews Institute, at Children's Health Andrews Institute in Plano, Texas. I specialize in pediatric spinal deformity and also in sports medicine injuries. And I hope that you'll find this useful. If you do have any questions or concerns, feel free to reach out to me. My email is at the bottom of this screen, and then it'll also be on the last screen of today's presentation. But we'll go ahead and get started today. So first of all, I don't have any disclosures regarding this talk, and we will go through this and teach you a few things. But first, I want to just go through and talk about the Andrews Institute, the Spine Center at Children's Health Plano. So this is a relatively new facility still, and we're a state-of-the-art facility where we have multiple things that can help with patients in the treatment of scoliosis and the evaluation of scoliosis, making this safer for them. Here at the facility, we're constantly trying to stay ahead of technology and innovation and new advances to accelerate the care for children. And we'll talk about some of those a little bit later. But as you can see in these pictures here, our location here in Plano, Texas, and then with the EOS machine, and that's an ultra-low dose scanning machine for scoliosis. And we'll discuss that a little bit later and how that can help children in their treatment as we evaluate them. So first, let's just go over the objectives of today. So first, we're going to define the normal spinal anatomy. We're going to look at that and discuss how that impacts scoliosis and how it also can impact motion and injuries throughout adolescent athletes and such. We'll define what actually counts as scoliosis and what the natural history of this disease is. From there, we'll identify how you identify spinal curvatures on a clinical examination. So we'll talk about kind of what to look for when you're trying to identify these. And then we'll identify treatment options for scoliosis and the need for early detection and how this can play a role in the treatment options that are available for scoliosis. All right, so when we first look at the anatomy, it's important to realize the different segments of motion. So injuries to the spine in young athletes can range from minor muscle sprains to life-changing, devastating injuries of the spinal cord, such as paralysis. It is important to understand the unique anatomy of the pediatric spine when looking at injuries, as this can change and can assist in diagnosing pathology or injuries that patients may undergo. First, we must understand that the spine is made up of several small vertebrae that combine to form what we call as the cervical, thoracic, and lumbar and sacrum regions of the spine. Each of these segments play significant roles in movement and protection of vital structures, with the majority of our spinal flexion and extension occurring in the lumbar spine versus minimal motion in the thoracic spine in order to protect the vital organs such as the heart and the lungs and things like that. So when we look at this, there are 7 cervical vertebrae. When we go down the back of the neck, you'll see a prominence at the base of the neck. The piece that sticks out the most there is what's called the C7 spinous process. So it helps us identify kind of the location of the spine that we're looking at. And then there's 12 thoracic vertebrae. These are going to be the vertebrae that hold the ribs together. And then there's going to be the 5 lumbar vertebrae in the lower part of the spine. And that's where, again, most of that spinal flexion and extension comes from. And when we look at the edge of the pelvis on a patient, so if we're looking at the top of the iliac crest, that's going to usually be equivalent to around the L4 or L5 space. And this can again help us with looking at anatomy and injuries and things like that. Especially for adolescent athletes, we're often looking at spondylolisthesis or PARS injuries, which is most commonly going to happen at the L5 level. So knowing where that L4, L5 level is can be important in the assessment. When we further look at the anatomy, we've got to look at the joints of the anatomy. So the shape of each vertebrae plays a role in how much motion it can have, and this helps us understand that from an injury perspective. When looking at the cervical spine, the facet joints, or which are the joints between the vertebrae, are relatively flat. You can see that in these upper images where it shows more of a thoracic spine vertebrae. But in the cervical spine, it is more flat, which allows for flexion and extension, but also allows for lateral bending and rotation. This is different from other areas of the spine, such as the thoracic spine, where the joints become more constrained, with the facet joints orienting more in a coronal plane. So as you can see up here in the upper images, how they start to angle more. This limits flexion extension, which is also limited by the rib attachments and other structures to this area, but ultimately prevents compression for the heart and lungs. In the lumbar spine, the facet joints become more vertical. This allows for sagittal motion, allows for flexible flexion and extension, but also limits rotation. So you'll see more rotation in the upper part of the spine versus flexion extension comes more from the lower part of the spine. This also helps with increasing abdominal pressure in the lower part of the spine, but then, as we stated, prevents downward flexion on the heart and lungs to prevent injury with that. When we look at the sagittal profile, it's really important to understand this and the differences that can happen with the sagittal profile. This can affect patients in many ways and lead to back pain and things like that when the sagittal profile is not in the proper placement. So when we examine the spine from the side, we're evaluating what's called the sagittal profile. There are normally 20 to 40 degrees of lordosis, which is dipping inward in the lower part of the spine. And then there's straightening in the cervical spine is often seen with cervical strains or other neck injuries. So we actually want to see that lordosis in the cervical spine and that dipping in. And if we don't see that, it could be an evidence of injury to that area. When we look at the thoracic area, we're normally seeing 20 to 50 degrees of kyphosis. That's going to be the roundedness of the back or that kind of humpback deformity. If we see straightening of this, it can also indicate injuries to that area, most commonly muscle strains, things like that into that area. And then when we look at lordosis, there should be about 20 to 80 degrees with an average of 60 degrees of lordosis. That's again, that dipping in. And most of this does occur between the L4 and S1 levels. And that's where we have injuries such as that spondylolisthesis or pars injuries that we talked about before. And that's because this increased lordosis puts extra stress into the facet joints in the narrow area of the spine called the pars interarticularis in the posterior aspect. When we look at the normal alignment, though, we should be able to draw a line. The line should go from the center of the C2 vertebral body down to the posterior corner of the sacrum, or S1. And as these images on the side show, you can see a negative sagittal balance versus a positive sagittal balance. And negative sagittal balance is where that line from that C7 vertebrae actually comes posterior to the S1 vertebrae. This can be seen with patients with lumbar hyperlordosis. And then when we see the positive sagittal balance, it's typically seen more with a hip flexion contracture or a flat back syndrome. So flat back syndrome is where we lose those normal contours of the sagittal profile. And this can lead to pain, but it can also be a sign of other injuries that could be ongoing. When we look at scoliosis itself, it's defined as a lateral deviation of the spine of at least 10 degrees. Because this is measured, it's a measured angulation for diagnosis. Scoliosis can only officially be diagnosed by radiographs. We will discuss this further on in this lecture. And in reality, however, scoliosis is much more complex than what we can observe on a single radiograph. On this x-ray here, you can see that this patient does have a significant curvature in their thoracic spine, measuring 47 degrees, and we'll talk about how we measure that later in this discussion. But this is a limited evaluation, even though that's what we base our diagnosis off of. In reality, scoliosis is much more complex than a simple 10-degree definition. And as one of my mentors has stated previously, Dr. Charles Melman, this represents a disturbance of an otherwise well-organized 25-member interarticulated series of spinal segments. In reality, it's a complex three-dimensional deformity. And what we mean by that is it not only bends, the spine also twists, which causes rotary changes or prominences in the ribs and things like that. So I recall or refer to it commonly as a roller coaster. So if you think about how a roller coaster will twist and spin as it goes through the changes, that's similar to the spine. It's rotating and bending. It's not just a bend. The ribs on the convex side of the curve often tend to thrust back because of this rotation, and that's where we'll be able to identify curvatures later, and we'll talk about that too, how we use that for further identification. When we look at congenital or the different types of scoliosis, there are three main types of scoliosis, and we break these down into congenital scoliosis, neuromuscular scoliosis, and idiopathic scoliosis. Each one of these has different properties to them, and we can break each one of these down into further categories also, but we'll stick with these main categories today. We'll break the idiopathic scoliosis down by age because each of these different types of idiopathic scoliosis do behave a little bit differently, and it is important to respect that and understand that infantile scoliosis is not the same as adolescent scoliosis. And often the treatment and the recommendations can be different between these. If we go to congenital scoliosis, this is a spinal curvature that develops due to failure of formation, failure of segmentation, or both during development. This typically will occur during the 4th and 6th weeks of gestation as the vertebral column is developing. This is also a time period of many other things developing, and we'll discuss how that affects things also. As these pictures demonstrate, patients can develop what's called a hemivertebrate, which is an extra vertebrae, as you can see on the remodeling of the CT scan in the middle picture, and then also down at the bottom where you can see the extra half of vertebrae. This can also present as a partial bony bar, which is where the vertebrae actually fail to segment, and you can have a bar between the vertebrae. This actually acts as a tether, preventing growth on that side, allowing the other side to grow, which can lead to a significant curvature. The worst case scenario is when we have a mix of that, of the hemibar and the hemivertebrate. So where we have one side where there's a bar and the other side has a hemivertebrate. This can lead to a rapid progressive curvature, and this can be very devastating for young children. We believe most of these are spontaneous in how they occur. However, there is a correlation with both maternal diabetes, alcohol use, valproic acid use, and hyperthermia that can lead to these through our studies. As we discussed, this happens during an important time phase of growth, so during the 4th and 6th weeks of gestation. And during this time period, there's lots of other structures that are also developing. So when we break this down, we see that there's about a 60% risk of associated systemic anomalies when you find congenital scoliosis. This is important to identify as a surgeon or as a physician in order to further evaluate for other things that could be wrong with the patient. We notice that about 10% of patients with with congenital scoliosis will have cardiac deformities. 25% or 1 in 4 will have genital urinary defects. So they do require an ultrasound of the kidney, and they also require a evaluation of the heart. And then about 20 to 40% will also demonstrate spinal cord malformations. This is important also because if the patient has a intraspinal abnormality that's playing a role in the curvature, we do not want to just straighten the curve, because this could cause problems with the nerves and the spinal cord itself. When these do progress, they most commonly are seen to progress during those first 3 years of growth. It's during the rapid phases of growth that we see this. And then we'll also see a potential for increased growth of this when they hit adolescence or hit puberty. If they can make it through those 2 times, we're usually okay with these. And a lot of these do not require any surgery or intervention, and we can just monitor them as they grow. If we don't do anything with these, though, they can lead to significant curvatures. And if the curvature is very large at a young age, it can prevent proper development of the lungs by decreasing that space for pulmonary development. We know that the cells of the lungs develop at a very young age, and if we are preventing those from developing by compression with the spinal cord with the spine leading to compression of the lungs, it can prevent that actual normal development and end up leading to pulmonary complications later in life for the child. When we look at neuromuscular scoliosis, this is a curve that develops secondary to neurologic pathology, including cerebral palsy, muscular dystrophy, paralysis, and other conditions. These problems most often lead to an imbalance within the muscles with high or low tone, which leads to changes in compressive or distractive forces on the spine. These forces then lead to a progressive curvature that can become very large and hard to control. One difference in neuromuscular scoliosis, though, compared to idiopathic scoliosis, is that even when curves are small, they're still at risk of further progression despite skeletal maturity. We'll discuss this later in idiopathic scoliosis and how skeletal maturity is very important in the risk of progression. When treating neuromuscular scoliosis, it is important to recognize the high risk of complications and comorbidities that the patients have. These patients should be treated at a facility that can provide a multimodality treatment care plan and that has experience treating these patients, as they carry a 10 to 30% risk of infection with the spinal surgery, which is very significant and can lead to multiple problems and multiple more surgeries for the patient. And there are studies that have demonstrated up to a 2% mortality for children undergoing neuromuscular scoliosis within the first 30 days. And when we start looking at idiopathic scoliosis, we'll start with the youngest age, and that's what we call infantile scoliosis. This is a curvature that develops in the spine without vertebral anomalies before the age 4 and accounts for about 4% of all scoliosis. These are significantly different curves that develop from different from curves that develop later in childhood. If we look at these curves, they are most commonly seen in boys, which we'll talk again later about how this is different from adolescent scoliosis, where it's more common in girls. They're also most commonly left thoracic versus idiopathic adolescent scoliosis is most commonly seen in the right thoracic region. And the real difference is that 80% of these will actually resolve on their own, which is a really good thing. There are several predictors, though, that can be used to determine the likelihood of spontaneous correction, and those often are required for X-ray measurements. One of these differences that we look for is a Cobb angle greater than 20 to 30 degrees. We do believe that these are likely to be more progressive and less likely to spontaneously correct. And there's also a measurement called a rib vertebral angle difference. And if we see this over 20 degrees, we do feel that this is a risk for further progression and unlikely to have spontaneous correction. If we do have patients that fail to improve or have curves that are greater than that 20 to 30 degrees, and we do believe are going to require treatment, we do recommend an MRI, as there have been studies that have shown that about 1 in 5 children with curves greater than 20 degrees will also have intraspinal abnormalities similar to, as we discussed, with the congenital scoliosis. Now, if patients fail to improve on their own, we can move on with casting. And so casting is something that really is only used in young children. And we've demonstrated that this is effective up until usually about age 5. And after that, the rates of correction with casting significantly decrease. But the most common form of casting is referred to as a metacast or a risser cast. These are a series of casts that are applied to the spine under general anesthesia and has to be applied every 2 to 3 months to allow for growth of the child. As the child grows, we have to exchange these casts out because, as you can see here in these images, the casts are very form-fitting around the thoracic and body. And in order to allow for breathing and development of the child, these do have to be changed out frequently. The changing also allows us to further correct the correction. So when we apply the body cast around the chest, abdomen, and upper pelvis, we put significant molding to further improve the curvature and to attempt to derotate the pelvis. You can also see on this image to the left how the child is strapped to a table. This does look kind of like a torture device, and everybody is a little shocked when they see it. But basically, we're wrapping a fabric around the pelvis, and we're pulling on the pelvis, and then we also have a chin strap that's going around the neck. And so we're elongating the patient with distraction, and then we're using the cast to also provide derotation for the spine. Initial studies by Dr. Mehta initially demonstrated that about 20% of patients that, 80% of patients will improve on their own with infantile scoliosis. But if we take those other 20% that do not improve on their own and we perform metacasting, she demonstrated that 80% of that 20% would go on for improvement and completely resolve scoliosis with spinal casting. Now, more recent studies, there was a more recent multi-center study that looked at multiple hospitals and a large group of patients that underwent metacasting, and they demonstrated only about 50% of patients that failed observation improved with casting. So maybe not quite as good as we thought for Dr. Mehta. However, if we do not perform this, then we have to start talking about surgical indications for correcting the scoliosis to prevent it from causing thoracic insufficiency and pulmonary problems later. So this is a much safer thing for kids to go through rather than multiple surgical procedures throughout their life. If we break it down to juvenile scoliosis, these are going to be curves typically seen between the ages of 4 and 10 years old. This is an extremely important curve to identify, as children this age have significant growth remaining, and these can be severely progressive if left untreated. These can ultimately lead to a significant impact on pulmonary development and cardiac function. These can be seen as right or left-sided curves, so it's a little bit different than both the infantile and the adolescent scoliosis. And these carry a risk of intraspinal abnormalities and therefore do require an MRI similar to the other forms of scoliosis as we previously discussed, the congenital and infantile scoliosis. These can be things such as tethered cords, syringomyelia, which is where the spinal cord is stuck, a spinal tumor, or Chiari malformations. Now, juvenile scoliosis can often be treated with observation, depending on the size of the curve and things like that. If the curve is very small, we often observe these. However, again, these patients are at a very high risk of developing a curvature that does require surgical intervention. So often we do have to intervene at an earlier age in order to prevent a significant deformity and prevent problems with lung development as they are growing. However, when kids are growing, we can't perform a spinal fusion, which is the most common form of spinal treatment for scoliosis. And we can't perform this because this will stop growth throughout the thoracic spine. And as you would think, children this age need to grow further in order for further development and expansion of that thoracic cavity. So we have developed several ways to do that. And one way is to perform bracing. And bracing is often the first form of treatment that is attempted. Unfortunately, this does require bracing potentially until they are done growing or until they are skeletally mature. So often this is not feasible, and often these patients will fail bracing. Another form of treatment is what's called a vertical expandable prosthetic titanium rib, or a vector. This is a device that's pictured here in the top that attaches to the ribs themselves and spreads the ribs, attempting to correct the spinal curvature. The advantage of this is that it does not involve the spine, so you're not causing any type of fusion throughout the spine by placing the instrumentation, which is a little bit different than the other forms of treatment, such as growing rods or magic rods or magnetically lengthening rods. The picture down here at the bottom is a standard traditional growing rod, and that's where we attach the rods to the spine at the top of the curve and at the bottom of the curve. curve. And then we leave the rest of the spine untouched, but we connect those two rods in the middle. And then about every 6 months, we have to go back in and we expand those rods to allow for growth as the child grows. Unfortunately, though, this does require multiple procedures and does have a high risk of complications because we are going through the same surgical incision multiple times over and over in order to lengthen those rods surgically. This requires many trips to the operating room and along with exposure to anesthesia. Now, magic rods are a relatively newer device, and these are what are called magnetic expansion control growing rods. And so this is similar to rods that have been used for lengthening of lower extremities and other extremities, where we put them over a magnetic rod or a rod that can be distracted by rotating the extremity. So in the spine, we do it similar to a traditional growing rod in that we connect the rod to the top and the bottom of the curvature. And then in between, there is this magnetically lengthening segment. And so every 3 to 4 months, the patient comes into the clinic and we place what's called an ERC onto the back. And then this allows for expansion of those rods. And so the patient will just lay in a position that allows for us to distract from the curvature. And often we have to do this, whether it's supine, prone, on their side, over a table, all sorts of different things to try to get a little bit of decreased pressure on the rod to allow for that rod to expand with the magnet. These have been great. It has saved many trips to the operating room for many patients because these often have to be changed out about every 2 years, 1.5 to 2 years versus every 6 months for a traditional growing rod. So ultimately, we do feel that this is safer for patients. However, there have been many concerns with these. Often the magnetic rod will fail to lengthen, which then does require us to go back in surgically. We have also, there are also concerns of what's called metallosis because this is moving metal within the spine. And we don't know exactly what is going to happen with that or what the overall impact long-term, especially in a very young child, may be with this. We've experienced this previously with metal-on-metal hips and hip replacement, and we have seen some issues with that. However, that is much more motion and debris that is forming compared to a magic rod. So we believe that the metallosis that's occurring with magic is significantly lower and unlikely to cause significant problems, but the reality is we really do not know at this time. So next, we'll talk about our main topic of today, adolescent idiopathic scoliosis. As previously stated, by definition, the etiology of the curve is unknown because it's idiopathic. That's what the word means. So it's different than neuromuscular and congenital scoliosis. There have been many theories as to why curves develop, and there is a genetic component as up to 30% of patients will report a family history. In fact, over a decade ago, it was thought that a gene had been identified that could predict who was at risk of progression of the curve, but it was later found to be inaccurate. It is believed that there is an X-linked pattern, however, because it is impacting females 10 to 1 for curves greater than 30 degrees. The overall incidence, though, of idiopathic scoliosis is found to be in a range of 2 to 4% in 10 to 16-year-old patients. However, more recent literature has actually indicated that this might be slightly lower, with only 0.3 to 0.5% of the adolescent population having curves greater than 20 degrees. I do want to point out again that this is most commonly in females for large curves. However, when we look at curves that are smaller, as far as what we call spinal asymmetry, that don't meet the 10-degree definition, it is equal between the two forms. This is the most common form of spinal deformity also seen among children. When curves form, they can form in several different patterns, but the most common form in adolescent idiopathic scoliosis is going to be a right thoracic curvature. As we stated previously, this does differ from infantile scoliosis, where it's most commonly a left thoracic curvature. And we also discussed how these are most commonly seen in females versus infantile scoliosis is more common in boys. Dr. Lanke also broke this down further and looked at different forms of curvatures. And the most common form is going to be a type 1 curvature, and that's going to be a main thoracic curvature. But then we can also break this down into double thoracic and double majors and triple major curves also. There's also a modifier that's applied to these, and that's based off of where the plumb line falls into the the center sacral line, crosses the lumbar vertebrae. When we can break these down into these classifications, it can also assist us in determining what levels require surgery and things for preoperative planning. So this has created a major step for scoliosis, and discussing scoliosis has given us parameters to where we can compare proper curvatures and establish proper treatment patterns based on different curvatures for this. Now, scoliosis is very common, and there are multiple famous actors, actresses, singers, athletes, everything with scoliosis, and most of us never really realize it. Now, most people do not go around telling people that they have scoliosis, but there are some people that have taken to social media and have made this part of their kind of role in educating people about this. So one person specifically was Martha Hunt, who is a former supermodel that worked with Victoria's Secret, and she has posted several Instagram and Facebook posts and things about scoliosis and trying to promote that. And you can see this picture of her here in her back, and she does have a surgical scar going down the middle of her back from where she did have surgery. One of my favorite ads was from the Summer Olympics several years ago, and it was about Usain Bolt having scoliosis, but he clearly was not broken by his scoliosis and was able to continue to be a strong athlete despite a spinal curvature. And I point that out because most of us, or a lot of us, have small spinal curvatures, and as long as they are not significant, they should not cause major impacts for us, and we should be able to continue to do anything in life without restrictions from our spinal curvature. So this brings us to how and when is a spinal curvature identified? Spinal curvatures are most commonly identified and formed during the rapid growth phase of adolescence. This typically occurs in females around the time of menarche or the initiation of their menstrual cycles, and which is typically around the age 12 in females. This initiation in males typically happens around puberty, which typically happens around the age of 14. So most of the time we will not identify curvatures, at least not idiopathic adolescent curvatures, until these ages. And while many physicians are the first to recognize a patient's curvatures on well-child examinations, there are several people that are at risk of not being diagnosed this way. For one, not everybody goes to their primary care physician for routine well-child examinations. And in areas that it is not very common for people to go to their primary care doctor, we have noticed that it is important for patients to be screened in other ways. So it's relatively rare that they're first noticed by family members, with the exception of occasionally during the summer months when patients are in swimsuits. This is when often patients will be noticed by families that their bodies are crooked or that they're standing leaning, things like that. But when children are going through their adolescent stages, it is unlikely or less common that they are walking around unclothed around families, and therefore families often miss this. Currently in the United States, less than half of the states have legislated school screening programs, with the remainder of them offering them. Currently, there is not a nationwide requirement or standard for how school screenings should be performed, and this is left to the state, county, city, or school district to decide. The American Academy of Orthopedic Surgery, though, recommends that screening should be performed in all females twice at both ages 11 and 13 in order to gain those early puberty patients, and then also the later ones, and then males only once at either age 13 or 14. We know that's less common for males to develop significant curvatures and scoliosis, and therefore we find it less necessary or less beneficial to screen males twice compared to females. This brings us to the state of Texas. The Texas state legislature currently requires all children, males and females, to be screened. But as of 2018, girls were only required to be screened. Females were required to be screened twice, once in 5th grade and again in 7th grade, and boys are required to be screened only once in 8th grade. This legislation is different from the past when males and females were both required to be screened twice, and it fits more with the recommendations of the American Academy of Orthopedic Surgery, as males are less likely to develop significant curvatures. There have been several studies evaluating the cost effectiveness of school screening programs, and the vast majority still find this to be beneficial. However, there are arguments, again, that in a population setting with high access to primary care, this may not be necessary. So next, let's talk about how to screen patients. So when performing a physical examination, it's important to have the child dressed in a manner that allows for clear visualization of the shoulders, trunk, and hips. The screen is not to diagnose scoliosis, as again, this does require an X-ray or radiograph, but to identify patients at risk. In this photo, there are several findings that point to a possible spinal curvature. First, we can see left shoulder elevation. We can see scapular prominence with lateral displacement of the scapula. We can see a right truncal shift where her whole body is shifted towards the right side. And we can see how the waist is asymmetric. According to the state and experienced examiner should be able to screen about 25 to 30 students per hour. So this should not take a long time to do. And we go through this of looking at different positions. So the main school screening is based on these positions listed here, where we're looking at the patient in multiple different planes from the front, the side, the back. And then we're also examining them with them bending forward. And we're looking for that rib hump. And we'll talk about this a little bit further later. It is important to notice, though, that only about 1.6% of all high school students have completely symmetric posture. So meaning that most people are going to have either one leg longer than the other, one shoulder a little bit off or unbalanced, and possibly a small curvature. So it is common to see slight differences, and we're trying to identify the patients that are at risk of true development of scoliosis or a progressive curvature. One way that school screenings are based off of, and often pediatric evaluations are based off of, is called the Adams forward bending test. This is a test where the patient leans forward using a Bunnell scoliometer to measure the amount of rotation the spine has. Now, again, we cannot diagnose scoliosis off of a clinical examination. Some spines will curve a little bit. Meanwhile, they will twist a lot, and some spines will curve a lot, but only twist a little bit. However, if we look at the overall evaluation, we see that if there is about a 7-degree rotary prominence, this should correlate with about a 20-degree coronal plane curvature. And it is recommended that patients with a rotational prominence of greater than 5 to 7 degrees be referred for further imaging in order to rule out a potential curvature. Even Bunnell himself, though, would make it say, or would tell you that we cannot diagnose this based on this. He demonstrated that there's wide variation in the amount of rotation of spinal curvature, and therefore we cannot accurately diagnose this, but it can be used as a screening tool. They have made this easier by the addition of the accelerometer in iPhones. So now there is actually tools that you can buy that's a small plastic holder, and I do recommend the holder if you are going to use your iPhone, because it does have a cutout for where the actual spinous process or the bone of the spine will go, preventing false measurements. But they've shown that this is equivalent for measuring rib humps to a scoliometer in spinal deformity patients, and this increases the access to care and the access to athletic trainers, nurses, school staffing, etc., to have the ability to have a scoliometer without purchasing one directly. There have been studies that show that this is equal. All right, so now we come to how do we diagnose this? Well, surface topography cannot accurately diagnose a scoliosis curvature, and therefore the formal diagnosis is based on radiographic measurements. The gold standard for diagnosis is based on standard standing x-rays and the measurement of what is referred to as a Cobb angle. This is a measurement made from the angle formed from the superior end plate of the top of the most tilted vertebrae and the inferior end plate of the bottom-most tilted vertebrae. This measurement does not account for the three-dimensional deformity that we discussed is prominent in scoliosis and important to identify, but it is simply based on the coronal view. This does have an intra-observer variability of 3 to 5 degrees. So I often tell patients that if my measurements are slightly different than a radiologist or another surgeon's measurements, that's okay. We know that there is difference in that. And when we're monitoring scoliosis, typically if we see less than a 5-degree change on a curvature, we say that that is not significant change, as we know that that can be just error in measurement. So numerous studies have demonstrated the long-term effects of radiation, and this becomes a concern for patients that undergo frequent monitoring. As shown here, patients that are diagnosed with scoliosis in the adolescent time period still end up with approximately 9 spine radiographs during the phase of monitoring, and multiple exposures at a young age to conventional x-rays had been shown to increase the risk of cancer and complications, especially with childbearing. Ideally, we will eventually find a way to better predict which curves require frequent monitoring and which do not, but until we do, we have to focus on decreasing the amount of exposure as much as possible. One way of doing this is using digital radiographs instead of conventional radiographs. A digital spine radiograph is equivalent to the background radiation, which is just the radiation that we're exposed to on a daily basis living on the planet, to a 10-day period. So basically getting one digital scolio x-ray is about the equivalent of living on the planet for 10 days. We also take these x-rays from the back to the front, and that's to decrease direct radiation exposure to the thyroid and breast tissue, ultimately decreasing the risk to the sensitive tissues of radiation. Another method to decrease radiation exposure that we implement here at the Andrews Institute is one called slot scanning X-ray techniques, also known as EOS. EOS is a system with two sets of X-ray tubes that are mounted at right angles, and this allows for simultaneous acquisition of frontal and lateral images. This has demonstrated 6 to 9 times less radiation exposure compared to digital radiographs, and when using a microdose protocol, it can be up to 26 times less radiation than digital radiograph. This is equal to less than 1 day of background radiation, and therefore we do feel that this is relatively safe because it is a very minimal dose of radiation that most of us are exposed to daily throughout our lives. So what happens after we have somebody that's diagnosed with scoliosis? Well, we have to first determine what is the goal of scoliosis. So the overall goal of treating scoliosis is to prevent a curvature from progressing and the comorbidities that can occur with large curvatures. And in order to do this, we want to prevent a thoracic curvature from reaching 50 degrees by the time of skeletal maturity and lumbar curvatures from reaching 40 to 45 degrees by the time of skeletal maturity. We state this because of other studies that have shown us the risk of progression. So if we look at these parameters and why those parameters were established, we notice that these were set based on who is at risk of having complications later. We know that pulmonary and cardiac compromise typically does not happen until curves are very large and when curves are greater than 80 to 90 degrees. So a 50-degree curve in itself isn't really concerning from causing problems, but we need to identify why is that concerning? Well, it's because of the risk of progression. So if we look at curves less than 30 degrees at skeletal maturity, it's unlikely that that patient will ever have significant progression and unlikely that they will ever need any form of treatment. And these are based on thoracic spine curvatures too, by the way. When we look at curves of 30 to 50 degrees, these likely will progress 10 to 15 degrees over time. However, this is not going to cause significant pulmonary or cardiac compromise, and therefore we typically do not recommend any surgical involvement for these curvatures. I often tell people I personally have a curvature that falls within that range, and I personally do not have any issues with it, and I do not find myself concerned over it as I finished growing decades ago. Now, where the concern, though, is when curves get over 50 degrees. When these curves are over 50 degrees, despite skeletal maturity, they're still at risk of progression of 1 to 2 degrees per year. Now, while this might not seem like a big deal, initially, if you add another 20 years of growth and you add another 40 degrees onto the 50-degree curve, next thing you know, you're at a 90-degree curve. This also becomes much more difficult to treat later in life as the spine becomes more rigid and more stiff, and we'll discuss that a little bit further later. Now, I would like to point out, though, that only about 10% of patients with adolescent idiopathic scoliosis ever progress to 50 degrees or more. So relatively uncommon that these patients are going to progress to a significant level. So then we have to determine who is at risk of progression. The most well-known risk factors for progression include the patient's gender. As previously discussed, females are at a significantly higher risk of significant curve progression and having large curvatures. They have a 10-to-1 rate of curves greater than 30 degrees when compared to males. We also have to look at the curve magnitude at the time of diagnosis, knowing that the larger the curve is at the diagnosis, the more likely they are going to reach that 50 degrees or a level that we are concerned about. And this leaves less room for safe progression to occur. And then we also have to look at how much growth potential is remaining, because again, growth is what makes small curves bigger. If we look back at that, small curves, once we're done growing, stay small. So we need to figure out who is at risk of that progression and who may reach that 50-degree curve based on the growth that they have remaining. There are multiple ways that we can do this. So we know that females typically start their menstrual cycles around the age 12 and will complete growth around 14. Males will typically hit puberty around the age 14 and finish growth around the age of 16. While this can provide a rough estimate, there is significant variation in this. So we have developed several ways we can predict a patient's remaining growth potential. If we go simply off chronological age, there's significant variation, but we do know that the older the patient is at the diagnosis, the less likely the curve will progress, as the curve as shown, as shown in the bottom left corner of the graph here. So the older the patient is, the less likely that they will progress because they have less time of growth remaining. If we look only at menstruation or menstrual cycles as a parameter, we can see in the bottom graph on the right that most females will start their rapid growth phase, known as their peak height velocity, shortly before starting their menstruation, and they will continue to grow for approximately 2 years after the initiation of menstruation. There are also several radiographic parameters that can be used to estimate growth potential. One parameter is the presence of the growth plate in the pelvis, known as the triradiate cartilage, which is shown in the top left here. This growth plate will likely close prior to the patient starting their peak height velocity or major growth spurt. Therefore, if we notice this on a radiograph, we are concerned that the patient still has significant growth remaining and has not hit that big growth spurt and is at risk of further progression. We can also look at a growth plate at the top of the pelvis known as the Risser sign. And while there is variation in this measurement also, this apophysis, which is a growth plate, does not typically ossify or turn into white bone until after puberty has started. So when we start to see a little white dot on the outside of the pelvis, we tend to think that the patient likely has gone through puberty, likely is or has gone through their fastest growth spurt. And as that white bar travels across the pelvis or becomes thicker, we know that they are traveling further and further into their growth and having less remaining growth available. The other option is also looking at a left hand. So we can do that by taking a picture of the hand, and there are multiple ways to look at it. One is called the Sanders classification, and another one is looking at the Gerlich-Pyle Atlas. So the Gerlich-Pyle Atlas is a book that was established based off of taking multiple pictures of people's hands at different ages and establishing what growth plates close and what order they close in the hand. And based on looking at those, we can then determine about how old the patient's bones are compared to their chronological age. Dr. Sanders also came up with a specific classification called the Sanders classification for this. And this is very similar, but it allows us to classify this based on a number pattern. And here's a picture of the Sanders classification. So if we start up in the first image on the top left, number 1, we can see that there are open growth plates throughout all the digits in the fingers. As we progress through the stages of growth, we can see how those growth plates sequentially close, and they start at the distal phalanx and then work their way down. And then there are also other growth plates at the base of the thumb and distal radius that we look at too for further evaluation. Once we can identify the Sanders classification, we can then use this to predict who is at risk. So this chart demonstrates the importance of curve magnitude at diagnosis and the skeletal maturity in regards to the risk of progression to curvatures greater than 50 degrees. As you can see, patients who are nearing skeletal maturity and have small curves are at low risk of ever progressing to a surgical level, versus patients with significant growth and large curves are at a high risk of surgical treatment. So down on the bottom left, you have patients that are very skeletally immature but with large curvatures, and they're demonstrating that red color indicating that they did proceed to surgical intervention. However, if you look at the opposite in the top right, you have people that are early in maturity or almost done with growth and have small curvatures are highly unlikely to ever reach a surgical level or a level that we need to treat. So how can we treat scoliosis? Well, there's several ways to treat scoliosis, and one is by observation. One is scoliosis-specific exercise programs, and then also bracing and surgery, and we'll talk on all these briefly. Observation remains the most common form of treatment for scoliosis. As we discussed, less than 10% of patients will demonstrate progression of the curve that will ever require any type of medical intervention. It's estimated that only 8 to 9% of patients with adolescent idiopathic scoliosis will meet the criteria that will require bracing, and only 1 in 1,000 will ever actually require surgery. Observation is usually indicated in curves less than 20 degrees at any age, and even much larger curves if nearing skeletal maturity, as the ultimate goal, again, is to prevent progression to that 40 to 50 degree curvature that we previously discussed based on the location of the curvature. If we do feel that observation is not enough for patients, we can discuss therapy. Now, in most instances, general physical therapy has not demonstrated significant benefit in curve management, as idiopathic scoliosis is not thought to be as a muscle problem, but rather a bone and disc problem. However, there is a specialized form of scoliosis, specific exercises known as Schroth therapy. This may provide minimal improvement in curvatures. However, this has not been clearly demonstrated in today's literature. The concept involves teaching patients about body positioning and using muscles and breathing techniques to derotate, elongate, and stabilize the spine in a corrected position. This can be quite labor intensive and requires significant effort from the patient and requirement of them doing daily exercises in compliance for potential success. Unfortunately, we don't know the long-term effects of Schroth therapy, and even if we do demonstrate initial improvement, it's likely going to require a lifelong commitment to these exercises for true success, because as patients stop doing the exercises, their muscles likely will change and become weak again and go back into the same position that the spine was in prior to this. Personally, I have mixed reviews on straw therapy. I think that there is a role for it. I think that it's definitely beneficial for young children that have not developed significant curvatures, but I do not feel that this is a solution for curvatures that are already at a surgical level, because it is going to be very hard and difficult for patients to maintain that position and maintain those exercises throughout their entire life, and therefore they are at risk of further progression. And the older that they are with progression, the harder that the surgery or intervention can be, and more risks with that. Now, if patients are at risk of progressing to a potential surgical level, we will often implement bracing to halt further progression of the curve as the patient is growing. It is important to understand that bracing is used during periods of growth and is not intended for skeletally mature patients, as the role of the brace is to decrease the compressive forces on the concave side of the spine and distractive forces on the convex side of the spine while a patient grows. So if you think about the way that growth happens, our growth responds to compression and distraction. So if we have more compression on a growth plate, it is unlikely to grow as much, versus distraction is going to cause more growth. So when we have a spinal curvature, we're having compression on the inside portion of the curve, and we're having distraction on the outside portion of the curve. This then leads to accelerated growth on the outside portion and slow growth on the inside portion, leading to further progression of the curvature. So if we can decrease those forces by putting them into a brace that straightens the curve or decreases the pressure, this will allow for the patient's spine to grow in a straighter pattern, not correcting the curvature that's already there, but preventing that curve from worsening as we grow. And then ultimately, the goal is, again, to prevent those curves from reaching a surgical level. So if we look at the different forms of bracing, there's multiple forms. And so the bottom left here is what's called a Boston TLSO type brace, and that's the most common standard form of bracing. Second to that is a Charleston nighttime brace. That's a bending brace, and that causes the patient to actually bend sideways and potentially reverse the curvature for correction. Unfortunately, because of the angle that this places the patient in, they usually cannot wear this during the day and can only wear this at nighttime while sleeping. The next brace is a Rigaud-Chenot brace. This is similar to a TLSO brace, but is more plastic defined with more contouring. So it attempts to overcorrect the spinal curvature, but still allow the patient to wear this throughout the day. This does have decreased compliance due to discomfort, and also can be harder to modify if there are changes within the brace, and therefore the Boston TLSO brace still remains the most common brace used. Another form of bracing would be a non-rigid form of bracing called a spine cord brace, and that's the bottom right corner here. Now, there are other forms, like I said, that are also out there, and each brace has pluses and minuses to them, and different levels of efficacy have been demonstrated with them. However, the one study that we have, the best study that we have for bracing, is based on the Boston type TLSO brace, TLSO brace. I'm sorry. This is something that was demonstrated about a decade ago to demonstrate efficacy. Prior to that, we never had anything to demonstrate that. So until the last decade, it was actually debated whether bracing actually worked and whether it was needed and things like that. This also led to debate about school screening programs, because even if we screen patients and we identify them early, if we can't do anything for it, is there any reason for that? Well, the BRACE trial, which was done by Dr. Weinstein, was the first randomized and blinded trial for bracing for scoliosis. The study was monumental and was actually stopped early and published in the New England Journal of Medicine due to the clear efficacy of bracing. Dr. Weinstein demonstrated that success was determined as preventing a curvature from reaching a cutoff of 50 degrees at skeletal maturity and becoming a surgical candidate. He demonstrated that there was a 75% success rate with bracing and only a 42% success rate among patients that were only observed. This indicated a number needed to treat in order to prevent surgery would be one patient in every 3. So basically, he noticed that for every 3 people that were treated with a brace, one of those 3 probably would have never gone on to meeting a surgical level. Problem is, we don't really know who that is yet. He also showed that 1 in 3 people even put into a brace still would go on to a surgical level. But that third, or that last 1 out of 3 patients that were put into a brace would actually avoid surgery that otherwise would have had surgery. So he did notice that treatment failure, though, in both groups was higher than expected, but still noticed that this was effective and was beneficial for patients. The other thing that came out of this was noticing that there was a significant dose response curve, meaning that you have to wear the brace. The more you wear the brace, the more successful this is. And we demonstrated that if you wore it less than 13 hours a day, it basically was equivalent to not wearing it in other studies. And he showed that 0 to 6 hours was the exact equivalent of not wearing the brace at all. So we ideally instruct patients to wear this brace a minimum of 18 hours per day, hoping that we get at least 14 to 16 hours out of them wearing the brace. Most patients will always overpredict how much they actually are wearing this. So now that we have a study that demonstrates efficacy of bracing, we have a reason to identify these patients at an early time period and more support to significantly support to using school screenings to identify these. This was a study out of Canada that showed that once they stopped school screening surveys, they noticed that 42% of patients had no significant deformity and were still in appropriate referrals. However, of those patients that were diagnosed with adolescent idiopathic scoliosis, 32% of patients that were identified and referred were late for bracing indications and therefore likely went on to progress to surgical levels. So if we are able to identify them at an earlier stage, there may be more inappropriate referrals or patients that did not need referral. However, we can also identify those patients that were at high risk of further progression and intervene at an earlier stage in hopes of preventing surgery for them. If scoliosis-specific exercises and bracing does not work and the curve continues to progress, most patients are recommended to undergo stabilization of the spine surgically. This is typically indicated for curves greater than 40 degrees in the lumbar region or in rapid growing patients, and therefore concern for further progression. But most commonly it's indicated for curvatures greater than 50 degrees in the mature adolescent, depending on curve location. We often do drop this to 45 degrees in the lower part of the spine. We typically recommend surgical stabilization at these levels, as our literature does or has demonstrated that significant risk of further progression once you have reached these levels, even despite skeletal maturity. Again, if we wait and we do not do a procedure at these levels, which again, the 50-degree curve is likely not, or is unlikely to be causing significant problems. But if we do continue to wait, the curve can become larger and more progressive. It can also become more stiff. If this becomes more progressive and larger, potentially we have to include further vertebrae or more areas of the spine in our surgical stabilization. And also, if the spine is very rigid or stiff, we often have to do more invasive procedures, such as removing vertebrae or removing pieces of vertebrae in order to allow for correction. This also then leads to further risk of complications such as neurologic risk injury, and therefore we feel that it is safer to intervene when the curve is relatively smaller and flexible, but still at risk of progression. This also is not to mention the fact that adolescents and kids typically heal a lot better than we do as adults and typically do better with pain control and things like that after surgery, have better healing potential, and they have less comorbidities, less problems with diabetes, heart problems, all those things when they're undergoing the surgery. So therefore, it is safer for them. Spinal fusion is the most commonly performed procedure for scoliosis and is considered the gold standard of surgical treatment. It is most commonly performed through a posterior approach or through the back and involves placement of instrumentation, which includes possible screws, hooks, rods, along with bone grafting along the spine. The ultimate goal of doing these procedures is to have the involved vertebrae fuse into one solid bone and therefore prevent any further progression of the curvature. Over the past several decades, there have been countless advancements in spinal fusion, including the advent of the pedicle screw, that have increased the safety and efficacy of surgery. Neuromonitoring is now a gold standard in scoliosis surgery and allows for the monitoring of nerve potentials throughout the procedure. And we are basically monitoring EMG signals throughout the upper and lower extremities to make sure that we do not cause any harm to these while we correct the spine. The nerves have been in a tight position for a long period of time. So if we go to straighten those, often that can cause problems with the nerves and can cause nerve injury. So we have to monitor that during surgery and often have to leave the patient with a small curvature in order to prevent further nerve injury. I personally often employ a technique that involves custom molds to be used in surgery for pedicle screw placement. You can see on these images to the left that when we are placing a pedicle screw, it's going through a portion of the vertebrae that is very narrow and it's very close to the spinal cord itself and also the spinal roots as they exit the spine. This is at high risk of injury if that screw is not placed in the proper position. When we're performing the surgery, we're only looking at the back of the spine, so it is very hard to identify that area and to make sure that we properly place that screw. Now, Now, this can be done just based on anatomy and feeling the bone itself. It can also be done off of x-ray. It can be done now with robotic assisted techniques, and then also with custom molds such as I use. Down here on the bottom, you can see that there's a 3D printed custom mold that's based off of preoperative imaging and preoperative planning that helps place the drill bit right where I have preoperatively planned for that screw to go. Now, ultimately, I still place the screw, I still drill all those things, and I still have to agree that I do feel that this is the proper placement for this. But this has significantly increased safety with scoliosis surgery, as it has documented accuracy of less than 2 millimeters. Once we have the spine in a straightened position, we then place bone graft in that area to make those bones feel like they're broken and to fuse into one solid bone. Once it's one solid bone, it can't bend, twist, or progress any further. Now, if we look at the amount of patients undergoing scoliosis surgery, there are thousands of patients in the United States that undergo spinal fusions yearly. In 2009, there were over 3,600 patients that underwent spinal fusions for idiopathic scoliosis alone. This is an extremely costly procedure, as seen here, and ranks second in total cost to the healthcare system, with appendicitis being number one for this age group. The latest published data that I could locate demonstrates an average cost of $185,000 per surgery for this. I would like to point out, however, that 29% of this was actually due to implant costs in this study. Ultimately, this significant cost helps support the need for school screening programs, with the thought that if we can limit the amount of children requiring surgery by early initiation of bracing and treatment, it will significantly decrease the overall medical costs and improve quality of life for the patients by ultimately eliminating the spinal fusion or surgery. Most patients will spend about 3 to 5 days in the hospital after undergoing a posterior spinal fusion for idiopathic scoliosis, and they're expected to miss about 3 to 4 weeks of school. This can be a heavy burden on the families to ensure care for the child during this time, and the child may be required to have homebound services for school, depending on the timing of surgery. Because of this, they are often encouraged to undergo the operation in the summer in order to prevent long absence from school. Following the surgery, the patient will be limited from certain activities, such as bending, twisting, lifting greater than 20 pounds. And this is often for at least the first 3 to 4 months. However, most patients can return to the majority of activities by 4 to 6 months after surgery. The spinal deformity group a few years ago demonstrated a consensus on returning to activities after spinal fusion for scoliosis. There really is not good data to support when to do these things, so we have to establish this based on a consensus of experts. And so most people said that it would be safe to return to running. They said that we can return to contact and non-contact sports around 6 months, but when we return to collision sports such as football, hockey, rugby, martial arts, wrestling, things like that, we need approximately 12 months. Now, again, there's limited data to support this. 20% of surgeons actually forbade any return to collision activities, and they were more likely to limit patients based on how low the fusion went. This makes sense if you think about it, because the lower that we go into the spine, the more motion we are taking away and the less segments of motion we have remaining. Therefore, if a patient were to have a traumatic injury, that motion has to come from somewhere, and it's going to come from the few remaining discs at the bottom of the spine if they're fused low into the spine. If they're only a thoracic fusion, you have all those levels of the lumbar spine to continue to allow for flexion and extension, and therefore is less likely to cause damage to the spinal cord or further damage to the remaining spinal canal. Most surgeons actually did not recommend physical therapy after surgery. Now, I will admit that I often do recommend therapy exercises to strengthen the shoulder and scapula stabilizers. And that's because as we do a spinal fusion, we have to remove the muscles that attach the scapula from the spine in order to place the hardware in order to create the fusion. We do reattach those at the end of the procedure. However, due to this injury and then also the restrictions that the patient undergoes for several months, they can develop significant weakness in this area, which then can lead to shoulder discomfort and pain following the procedure. Another study in the Journal of Pediatric Orthopedics evaluated 42 spinal fusions and found that return to playing sport was on average of 7.4 months. They showed that 5.5 years after surgery, 60% of the athletes had returned to an equal or higher level of participation in sport. And when they looked at the most common reasons not to return, they showed that it was decreased flexibility, back pain, and deconditioning. Again, these children are restricted from sports for a long period of time, so there is a lot of deconditioning that can occur during this. And often patients just decide not to return after being out of sports for that long. Again, distal fusion level, though, is a significant predictor of return to play. And this, again, is likely secondary to the amount of motion that is being removed by going further into the lower part of the spine. That brings us to where are we today and where are we going with this and what can we do to make this better for patients? Because spinal fusions obviously are not ideal in that they do limit some motion, even though most studies will show that you will regain full flexion and things like that and will be able to participate in most activities. But ideally, we'd like to be able to maintain motion. We do find that about 15% of patients that undergo surgery do require a second surgery for scoliosis later in life or for other problems within the spine. And this is a lot of times due to degeneration of other segments of the spine. Again, if you're taking away motion in other areas of the spine, we have to make up for that in some way, and that's usually through discs remaining at the bottom of the spinal fusion. This can lead to wear and tear of those discs and potential need for further expansion of the fusion later in life. So it brings us back to a different type of procedure that we have been doing for decades. So orthopedic surgeons have known and studied a procedure called guided growth of the extremities. This has been based in extremities been used in extremities, to modify the alignment of limbs, including Blount's deformity or a significant bow leg deformity position. This is often done by placing a plate with screws above and below the growth plate on the long side of the extremity. This then tethers or slows that growth plate on that side, giving that compression we talked about, like in scoliosis, and allowing the other side to continue to grow. This then allows for correction of the deformity as the patient grows. Now, this can be complex, as we can often see rebound growth, meaning that when we do obtain correction, if we take those plates off, we can see the deformity reoccur. We can also see overcorrection if we allow those plates to stay in too long. So ultimately, this type of procedure requires proper timing of the procedure in order to obtain proper correction, but also avoid overcorrection or the possibility of rebound correction if we do have to remove that hardware. These images demonstrate children with bow-legged positions that underwent guided growth of the outer portion of the tibia and femur, respectively. You can see how, with time and growth, the deformity has slowly corrected. Well, this has then been brought to the spine. And what can we do with the spine? Can we perform guided growth of the spine? Well, we have now developed a technique called vertebral band tethering. There have been multiple implants that have been investigated for a similar technique previously, but the vertebral band tether is the first device for its use that has obtained FDA approval in the United States. The FDA approval occurred in 2019, and while it's still investigative, this is a big advancement in perfecting a technique that could become the mainstay of treatment for scoliosis. And currently, there have been about 1,000 procedures that have been performed. The development of this and the use of this has been slightly slowed due to the pandemic and being able to train surgeons and be able to perform the surgeries and things during that time. The numbers are drastically increasing over the past year. And again, this is becoming a more common procedure seen throughout the United States. However, there's still only approximately 150 to 200 surgeons that are trained on this technique. If we look at vertebral band tethering and how it differs from a spinal fusion, it involves a thoracoscopy approach to the spine, where for thoracic curves, and then also an open procedure potentially for the lumbar curves. Now, if we're doing this in the thoracic spine, we place the patient on the side, as we can see here in these images with the patient laying down. We actually place a big bump to try to distract that curvature. So we're on we have the convex side of the curvature on top, and we're placing them on their side to try to flatten that curvature to give us correction during the procedure. And then we're going in through the thoracic cavity. So we're actually dropping the lung on that side and allowing us to go in with a camera. And we place screws on the side of the vertebrae rather than posterior to the vertebrae, as in a posterior spinal fusion. We then take these screw heads and we place a cable through those screw heads. These are then attached with little set screws, or little screws that clamp that cable into the heads of the screw. This allows for immediate correction and also allows for tethering for that guided growth correction. The advantage of this is several, in that one, it's because it allows for motion, so it takes away the need for a fusion in this area. But because it allows for motion, we also see implant failure, which has been a big problem and concern early on in the stages of development of this, but has been significantly decreased based on new techniques of placing this cable. Here's a picture of a patient with a 41-degree curve that underwent correction, and you can see how they have really corrected that curvature and they've really straightened out the curvature with time. Now, depending on if this patient has significant growth remaining, things like that, we may have to actually go in and remove that cable in order to prevent overcorrection. Or if the cable breaks, the patient may not obtain full correction. So it is something that we still have to continue to monitor throughout growth. And if we look at who is a proper candidate for vertebral band tethering, this has been debated. And so we have had several factors that can predict success versus early failure. And this is something that we've demonstrated through the cases that we've done and continues to change. And we likely will continue to see the parameters and indications change throughout time. But what's one of the most important factors of success of this is patient selection. At this time, it's recommended that the procedure is only performed in skeletally immature or growing patients with significant flexibility on preoperative imaging. On preoperative imaging, we want to show bending radiographs demonstrating improvement of the curves to less than 30 to 35 degrees. We know that when we stand after surgery, we're going to lose some correction. So in surgery, our goal is to try to get that curve to be less than 20 degrees. There are also limitations with this procedure in that it does not significantly correct rotation or kyphosis, and therefore these can be contraindications to performing the procedure. So why VBT? Why vertebral band tethering? Well, the main interest in tethering comes from the fact that it's fusionless spine surgery. This should not significantly impact motion because we're not fusing that area. This is particularly important in the lumbar spine due to the extreme amount of flexion and extension that normally occurs in the lumbar spine and the possible degeneration that can further occur distal to a fusion, secondary to increased demand on those remaining segments, as we had talked previously. So if we allow for continued motion, then we shouldn't see that further breakdown. This is also has increased interest because of the decreased limitations following the surgery and quicker healing time. So with this type of procedure, we're actually demonstrating that we can get patients back to full recovery or back to returning to activities at a faster rate. And typically we're saying this is between 8 to 10 weeks that they can return to full activities versus, as we discussed before, potentially 6 to 12 months for certain sports and certain activities. And this is feasible because we aren't doing as much muscle dissection and we don't have to require that bony fusion before we can allow them to return to activities. So overall review of today's talk. So we talked about how scoliosis is a complex three-dimensional deformity that can only be diagnosed on radiographs, but can be found on clinical examination. And often we're looking for that rib prominence when patients bend forward in order to identify a possible curvature. We also know that most patients will not require formal treatment and most can be observed. So just because someone is diagnosed with scoliosis does not mean that they have any restrictions or that they can't participate in activities or that any type of activity is going to cause any further damage to their spine or cause worsening of their progression. Most people don't require any treatment or any restrictions in their life. Now, early detection is important to allow for potential bracing, and that's again where school screenings can be beneficial, and having both athletic trainers, nurses, everything at school watching for scoliosis or identifying spinal curvatures can be beneficial. And then surgery is indicated for curves that are at risk of further progression after skeletal maturity. And these are curves that are going to be greater than 50 degrees in the thoracic spine at skeletal maturity, or curves that are greater than 40-45 in the lumbar spine at skeletal maturity. Small curves should only significantly increase during phases of growth and should not further progress once we are done growing. And that brings us to the end. And thank you very much for joining us today. Again, if you have any questions or concerns, you're more than welcome to reach out to me. My email address is here on the screen. And I hope that this was educational for you and beneficial. And thanks for spending your time with me.